Welcome to the Hope After Narcissistic Abuse podcast. I am your host, Amy Helms. Each week, you will hear from experts across the country and even world speak to you on recovering from narcissistic abuse and even how to manage these relationships. You will also hear some periodic solo episodes on how to manage these relationships and what recovery is like. It is my hope that you will leave each episode with some renewed hope that you can and will beat this. Thank you for tuning in. Hey, and welcome to another episode of Hope After Narcissistic Abuse. Today, I am so excited to welcome Dr. Linda Bluestein. She is a board-certified anesthesiologist, integrative in pain medicine, and also a former ballet dancer. She specializes in treating and educating dancers and other athletes about the increased risk of hypermobility disorders. She contributed in 2 chapters in the book, Disjointed and Navigating Diagnosis of Management of Hypermobile Ehlers-Danlos Syndrome. She is also, don't mind saying this, I've consulted with her myself for my own hypermobility issues. And she's an all-around fabulous person, and I can't wait for her to share her wisdom with everyone. Thank you, Dr. Bluestein.
Oh, thank you so much. That's so sweet.
So you've gone from being in the operating room to establishing this great new business to help people. Can you tell us a little bit about what you're doing?
Yeah, so it's funny because probably what people would have perceived from the outside as being the highlight of my career, I was working full time, I had kids, everything looked on the outside like it was going really well, but it was not at all. My body was having more and more problems, and I ended up ultimately having to leave the operating room because I just couldn't do a lot of the tasks that you need to do because of my own hypermobility related problems. So I left the operating room a number of years ago and was kind of trying to figure out what I was going to do with myself. And in the meantime, started really working on how to help myself feel better, because I had been at a really low point in my life. I was in so much pain, and all I could do was talk about it. And my husband was like, "Oh, I'm so tired of hearing you talk about this all the time." And so I kind of was working on getting myself to feel better, and had really made some really nice progress. And along the way had met some people who were just really helped me to learn a lot more about these conditions. And one of them, Dr. Pradeep Chopra, who also is an anesthesiologist, and he does pain management for people with EDS and HSD, he convinced me to open a clinic. So I had written an article, a journal article, and people were contacting me and saying, "Where can we come see you?" And I had to say, "I don't have a place." And then he convinced me to open a clinic. So then I opened a clinic in 2017.
When you were in the process of not feeling well, leaving the OR, did you already know about your hypermobility, or was that something you had to kind of figure out yourself?
Yeah, that's an interesting question. So I had worked at the same hospital for 14 years. And during that part, I did not know what was wrong with me. I literally kept saying to my doctors, "Something is wrong with me. I don't know what it is, but I get injured really easily. All these things hurt." I was aware that the bright lights, you would have to look to see like where are they at in the surgery, and the bright lights from the that they would have, the surgeons would have to do their work, were really starting to bother me. And I would get migraines all the time. And, I'd get all of a sudden the monitor, the lines would be wavy. It would be hard to read the numbers. And, you're stuck in a room, and you don't even have like water or anything in order to take something to try to abort a migraine right away. So I was running into some other difficulties like that. But when I first was working for that long stretch at one hospital and started really having a lot of problems, I did not know what was going on. I did get my diagnosis of hypermobile EDS. In fact, at one point he suspected classical, but I'm quite sure that that's not the case. But anyway, so that was in 2012. And then I ended up working from 2011 to the end of 2015, I ended up doing something called locum tenens, which is where you're working like a substitute teacher almost, where you go to different hospitals and you fill in for anesthesiologists that are on maternity leave or whatever. So during that time, I did know what was going on. And so I was better able to pace myself. And, I'd go back to my hotel room and I'd lay down and I'd stretch or, gently stretch, use a heating pad, ice, whatever. And I was able to much more better control my schedule, because instead of having to request vacation and having to otherwise work, for that 14 years, I worked incredibly long hours. It was really physically demanding on my body. And when I was doing the locum tenens, I say yes or no to any given assignment. So instead of having to choose when to be off work, instead I could choose when I wanted to work. So that was good.
Right. Because I think that's what so many of probably the listeners and people going through this themselves are going through, is, years and years of chasing down symptoms and being told, it's one thing or the other.
Mm-hmm.
In my practice, I have 3 patients with Ehlers-Danlos, and then I sent one to be evaluated, but they all come with the same stories. Well, they tell me I'm a woman, I'm too anxious, or I just need to rest, or I probably need to take a break. It's hard being a XYZ. What do you say to people that tell you stories like that?
Yeah, I hear that all the time, and it's so hard. I mean, I do think that as women, we are taken less seriously. I feel really confident that, and I know there is some data to back this up, that when men come into the emergency room or into an office, that they are taken more seriously. Now, part of it is they do wait in general. A lot of them wait a really long time to get care. So there probably is some data to back up that, for example, I remember as a child telling my mother, well, the one advantage of us, and I must have known something about her body at this time, I said, we're not going to be one of those people who goes to the hospital and has a massive tumor. Like, I knew as a child that I had more awareness of what was going on in my body, like as a young child. And I was quoted in the newspaper at age 16 talking about dancers and their injuries. So I've been fascinated since a very young age about why some bodies are different from other bodies. I have a family member, not genetically related, but that has so much damage in their body. I mean, you can look at their body and there's all kinds of alignment problems and this, but no pain, and then there's people who they look perfectly fine, but things hurt. So we know that bodies are built so differently, and it's complex. It's not just damage equals pain. Pain is an experience. And it is based on a lot of genetic factors. It is based on things, like EDS or HSD, where we have these joint instability, joint malalignment, little micro tears and things like that give input constantly into the nervous system. And the nervous system starts going, wait, what's going on? I better start looking for problems, and starts to get sensitized. And so we know that people are very, very different in terms of how they experience pain. And I know we're going to talk about trauma too. That's a huge, huge factor in pain as well.
Right. So, well, that kind of brings me to what I was going to ask you, is because you're talking about the nervous system, and trauma is the nervous system. We store it in our nervous system. So how does that impact everything you're talking about?
Yeah, so I think that whether it's because of traumatic experiences or if there's some other reason why your sympathetic nervous system, so your autonomic nervous system is divided into the sympathetic nervous system and the parasympathetic nervous system, and they're supposed to be in balance with each other. And the sympathetic nervous system is the fight, flight, or freeze. And that's you get into a car accident, or you almost get into a car accident, and you just feel your heart race and all of that. You can just tell your gut is going to shut down when that happens, because digestion is not the priority at that point. So it's a balance of the sympathetic nervous system, the fight, flight, or freeze, and the parasympathetic nervous system, the rest, digest, and restore. And some people are just more parasympathetically predisposed than other people. Some of us, we have more anxiety. Our sympathetic nervous system is just more, more on overdrive. We get like startled really easily. I will know that my husband is in the house, and yet, he comes around the corner and I just jump, and I'll come home and he had no idea I was coming home, and he's like, oh, it's just, we're completely wired differently. So whether it's because of trauma or some innate, differences in how we're wired, we really know that there is a huge impact of the sympathetic nervous system and the autonomic nervous system on how we process pain and how much pain we sense. And a lot of people, and to me, the really tragic thing is that when people go to the doctor, they go in feeling very hopeful. Here they're, and oftentimes they have to wait a long time, right? So here they're going in for this appointment and they're like, okay, I'm going to get help. Maybe they're not going to have all the answers, but at least I'm going to walk out feeling hopeful about things. I'm going in hopeful, thinking that this is going to be, the next step in my feeling better. And instead, so often they walk away so disappointed because not only did they not get any answers, but they were made to believe that they were crazy, lazy, making things up. Oh no, that's not possible. It's not possible for these things to be happening. And so it's really, really hard. And I've had that happen to me with my own healthcare. And it was psychologically devastating. And rather than saying, no, I know what I'm feeling in my body, and I know that, I need to work on getting answers. Instead, I doubted myself, like so many other people do. So the first thing I would say is don't doubt yourself. If your doctor doubts you, that doesn't mean that you have to doubt you. So that's the first thing I would say is don't doubt yourself. If your family members and your friends doubt you, that still means don't doubt yourself. Like what you feel. And that is very, very important. The other thing is you only need really one advocate. You need one person to help you kind of get the ball rolling. So I know sometimes people get really fixated on, for example, seeing a geneticist. So they suspect that they have they have symptomatic joint hypermobility. So they have joints that have greater than average range of motion, and they have symptoms that are likely attributable to that. And they think that they might have one of the Ehlers-Danlos syndromes, for example. So they want to see a geneticist. It's not that that's wrong, but it can be very, very hard to get in to see the geneticist. And so sometimes, they get kind of fixated on that rather than looking for a person. It could be a PCP, it could be a rheumatologist, it could be a PM&R doctor. It might be your physical therapist, finding somebody, it could be somebody, it could be you. Finding a person to help you get things rolling and to be somebody supportive. Like a lot of people don't have enough supportive people in their life, and it might not be your immediate family. It might not be who you expect it to be, but if you have a couple of supportive people in your life, if you can find a healthcare professional that is open-minded and that is empathetic, that's often enough to get the ball rolling.
I think that's how a lot of people out of these abusive relationships is they are isolated.
Yes.
And they don't have the friends or family to go to. And then they probably haven't mentioned anything about the abuse to the physician or so then it is kind of a fresh start. But so can you break down, we've been talking about the Ehlers-Danlos hypermobility. It's just a spectrum. And I think that to get back to your point of genetic testing, does it really matter which one it is? Because we're treating symptoms, right? We want to get better. But can you kind of describe, or just do a general overview of, what this is, what these initials are we're talking about?
Sure. Yeah, absolutely. And before I forget, there is one type of EDS, the vascular type, that is very important to diagnose because that is a life-threatening type.
Yes, my daughter Googled that one.
Oh, really?
And came to me in tears. So I was like,
oh, no.
We would know if I had that by now because I'm at that age range.
Right. Oh no. Yeah. Okay, so I'll back up, but I just want to make sure I don't forget to put that in there. So the Ehlers-Danlos syndromes is actually a group of 14 different connective tissue disorders, or 14 different subtypes of Ehlers-Danlos syndromes. And the Ehlers-Danlos syndromes are one of the hereditary disorders of connective tissue. So connective tissue is basically present all throughout your body, and it's basically like the glue that holds your body together. So we used to think that all of the problems with the Ehlers-Danlos syndromes were all related to collagen, but now we know that it's not just collagen, it's all the things that are in what's called the extracellular matrix. So basically the things that are between the cells and relate to cells adhering to one another and things like that. So the Ehlers-Danlos syndromes, again, are a group of disorders. There's 14 different subtypes, and there's one subtype, the vascular subtype, that can be life-threatening. I shouldn't say, some of the others, you can get comorbidities and that can be life-threatening, but the vascular subtype is very important to recognize because there are things that we can do to treat that, to hopefully give the person a more normal lifespan. So the most common subtype, though, the hypermobile type, is unfortunately the only subtype that we are not currently able to demonstrate on genetic testing. We know the genetic markers for the other subtypes. So we can do genetic testing for the vascular subtype, for the classical subtype, for the classical-like, all these other subtypes. We can do genetic testing and we can demonstrate if a person has that or not. But the hypermobile type is by far the most common type. We think that probably 80 to 90% of people with EDS, or Ehlers-Danlos syndrome, have the hypermobile type. So, you know, a lot of questions regarding the prevalence of EDS, and it's very difficult because we've changed the nosology, or the terminology, over the years. And in 2017, the diagnostic criteria for the hypermobile subtype became much more strict. So it's really, really hard to know what the prevalence of these conditions are. But if we lump together hypermobile Ehlers-Danlos syndrome and something called hypermobility spectrum disorder, or HSD, and HSD is basically if you have symptomatic joint hypermobility, but you don't meet the criteria for any of the hereditary disorders of connective tissue, including all the subtypes of EDS, and there's not another condition to explain your symptoms, then we say you have hypermobility spectrum disorder. It's kind of like the irritable bowel syndrome, you know, for symptomatic joint hypermobility. And so we think that the prevalence of probably the Ehlers-Danlos syndromes and HSD together is probably 1 in 500, or it might even be higher than that. But there was a study done a few years ago that looked at, prior to that, we were using the term joint hypermobility syndrome. So they looked at a combined prevalence of joint hypermobility syndrome and EDS, and they came up with a prevalence of 1 in 500. But interestingly, you could really see the curve, and the diagnoses had greatly been increasing over time as these conditions are getting better recognized. So I think it's probably higher than 1 in 500.
I'm thinking of people that I know in my practice, that kind of has to be either that or it's just, you know, I need to win the lottery.
Yeah, and it's really interesting because there's also some theories floating around that mast cell activation syndrome, so mast cells are a part of our immune system, and they contain hundreds of chemicals inside of them, and they can activate a bunch of chemical mediators. And when those mediators are released, there are effects all throughout the body, including degradation of connective tissue. So there was a great paper written by my friend and colleague, Dr. Lawrence Afrin, titled "Some Cases of Hypermobile Ehlers-Danlos Syndrome May Be Rooted in Mast Cell Activation Syndrome." So it is possible that some people who have the clinical picture that looks like hypermobile EDS, that they actually don't have a genetic defect, but that instead they've been exposed to all of these chemicals in the environment, pesticides, pollutants, you know, off-gassing of things, and their mast cells have gotten activated, release these mediators, which degrade their connective tissue, and now they have symptomatic joint hypermobility.
Right. So with mast cells being, you know, an immune modulator, how are those affected with PTSD?
Oh, yes, definitely. I'm glad you asked that question. Yes, they are very much impacted. One of the articles that I pass out a lot to my patients and my clients, it's by Dr. Theo Theodoris, and it's titled The Impact of Psychologic Stress on the Mast Cell or on mast cells. And we know that conditions like asthma, eczema, allergic rhinitis, like all of these mast cell related conditions are exacerbated by psychological stress. I remember when I was a kid and I had asthma and I would be at a friend's house or something and I would start wheezing, and then they would call my mom and say, you need to come pick her up. She's having an asthma attack. And it usually was blamed on, psychological stress. And probably that was one of the confounding variables for sure, because I've had anxiety my entire life, but it's like we were talking about before we started recording, like the chicken and the egg. Because of course, if you have mast cells that are trigger happy and releasing all of these chemicals all throughout the body, of course, you're going to feel anxious. And you are going to be more predisposed towards psychological stress. So it's really hard to know what's the chicken and what's the egg. But if we can do things to try to lower our psychological stress, and I should say distress, because stress is something that we have, and it's not all bad. Like getting married, that's a stressful event, but hopefully that's a happy event.
Speaking of the wrong person.
Yeah, right. Yeah, true. But distress is when the stress is it exceeds the levels with which we can cope.
So then, are you seeing cases where you're seeing like the onset of the hypermobility spectrum or the mast cells increase after a traumatic event?
Definitely. Yeah, that is definitely a common thing. And I go through a timeline with people, and I like for them to tell me their story for a couple of reasons. One, I find it much easier to remember them, and I feel like I get to know them as a person better. And then two, as they're telling me the story, oftentimes they remember things, or things come up that they didn't put in their forms, their intake forms. Oh, I forgot about this. I forgot about that. And as they're telling their story, oftentimes, things come to the forefront that are very, very important variables. They lost a child, they had a divorce, they had an abusive partner. I mean, these are things that I just hear over and over and over again. And I think, it makes sense that these things affect our nervous system, and our nervous system is extremely important for the processing of pain signals in the appropriate way. Like our body is supposed to filter out a certain amount of pain. We're not supposed to feel pain with every little thing. But when our nervous system is just, fired up, it really makes a huge difference. And I think that, Dr. Chopra told me before I opened my practice, he said, you will see a lot of people with adverse childhood experiences, or ACEs, in your practice. And in the beginning, I did collect ACE scores. There's a validated questionnaire for ACE scores. But then I found kind of going through the story was more helpful, because not everything is included on the ACE score. And of course, all of us have had some childhood trauma. I mean, you don't get through being a child without some trauma.
Right. And some things that are on there are traumas to ACEs, but not, we would consider our traumas bigger than that. Best friend moving, something like that, changing school, but that's not on the ACE criteria. So
right.
I think it has to be a life story.
Yeah, exactly.
So, I deal, with a lot of, women that, are out of abusive relationships in those, and they come into my office and you can tell they're rigid, they're all uptight. So there's we see their pain because of the way they're sitting and posturing, but we also know that, trauma can cause pain as well. What do you say to people that are just seeking answers? Why am I hurting all the time? Do I have to hurt all the time?
I believe that most cases of people that are hurting, especially if it's widespread body pain, that there is a way to be feeling somewhat better. There are some conditions that cause what's called intractable pain. And in that case, oftentimes the only option really is like opioids, which to me is kind of a last resort. Like that's like a different path to me. You have intractable pain, you have this condition that is just, there's just really not another answer for that. And so that's kind of one path. But for most people, I feel like there are things that we can do, including some programs that will help rewire the nervous system. And oftentimes they can do, there's like some apps and books. And I believe education is so important. And that's why I love this podcast that you're doing, because I think that when people understand how the nervous system works, it's really, really helpful. I'll tell a quick story about that. So it was around 2014, maybe. I was on call. I was doing, the locum tenens. I was on call at a hospital, and I was in a lot of pain. And so I went to the call room and I laid down, and I got out my computer and I was looking on YouTube for whatever reason. And I came across a lecture by Dr. Daniel Claw on central sensitization. And I watched that lecture. Now, keep in mind, I'm working as an anesthesiologist. I've been all the way through med school, all the way through residency, biological sciences, undergrad, but still, like, this is newer science. And I'm watching this, and the light bulb went off in my head, like, oh my gosh, this is what's happened to my body. This is why everything hurts. And at the same time that it was like a little bit frightening, it was also empowering, because I realized, well, if this can make me feel worse, then maybe I can use this to make myself feel better. So I really started to dig in to the literature and try to figure out, okay, how can we reverse this sensitization that has taken place? And it's not easy, and it doesn't happen overnight, because the nervous system and the brain, when you've been in pain for a while, we actually can see structural changes in the brain if we do like functional MRI scanning and things like that. So it takes a while for the brain to, we don't know how much of those changes can be reversed, but I do believe that in a lot of cases we can improve someone's perception of pain. Now, it is hard because obviously it's not like you can go into, most of the time, to your PCP and say, what can I do to help undo my whole body widespread pain? It's not like most PCPs know how to handle that, but there is a lot of information available now online. And that's part of why I started my podcast, Bendy Bodies with the Hypermobility MD. I'll give a plug for that because I wanted to be able to share free information with people so they could take some steps on their own, because I know that a lot of people don't have a supportive medical team.
And I'll give a disclaimer I always give that, while Dr. Bluestein and I are both licensed clinicians, we're doing this for entertainment purposes only, and this is not medical advice, or should you consider it to be something you should be doing. But that being said, so you created this coaching program. Tell us a little bit about it. Give it a plug.
So are you talking about the EduCoaching?
Well, the entire program you've built, because you've and I know you've done this in part because there aren't answers out there. I know there's no one in South Carolina where I am that even really knows what all this is. And right. I know people all over the country are kind of searching for answers. So
and the way medical licenses work is they are state dependent. So I currently have a license in Wisconsin and in Colorado, but there are people that live in other places besides Wisconsin and Colorado that need help.
So I see Dr. Bluestein for coaching, and it's just she collaborates with my physician. I don't mind we're disclosing that, but of course this podcast is not medical advice. This is just entertainment.
Right. It's not medical advice because we don't know any given listener, we don't know their situation, right? So that's why it's not medical advice. It's not advice specific to one person because we don't know their story. We don't know their situation. But I find that, I was trying to figure out how can I help people they live outside the US. They live outside of those 2 states that I'm licensed in. At the beginning of the pandemic, I was licensed in a bunch of states because like Georgia made it so easy. They were wonderful. It was like, you fill out, I think it was a single page form, and I don't even think I had to pay anything. And then they kept renewing everyone's emergency license unless there was a reason not to. So
I got licensed as a therapist there, and I had to send my high school transcripts.
Oh yeah, I know. When I got licensed in the state of Washington, I had to submit fingerprints, and the first set of fingerprints were not adequate. So I had to do my fingerprints again, and it was outrageously expensive. So I didn't end up renewing my license there, actually. So I tried to figure out, like, okay, how can I help people? So I have the free podcast, which, like this, it's, it's information that you're putting out to a lot of people, and you hope that people find it helpful. But yeah, it's educational and it's entertainment, but it's not advice. It's not specific advice. And I thought, okay, well, can I do like one-on-one coaching where it's not medical advice? It is information for the person to work with their own healthcare team. But I feel like it's kind of like doing the detective work for your team. And so I always give people access to the whole note. And I say, take this note, print it, do whatever you want to do with it, highlight certain parts of it, and take it to your healthcare team and show them, look, I saw this doctor. This is what we talked about. Is this something that you think you could prescribe for me? And depending on what option people choose, I often will talk to their healthcare team directly and say, look, this is what I prescribe often for my patients. And I find that to be very helpful. And they usually have questions. Well, how do you prescribe it? Exactly what dose and all those kinds of things. And so I will give them that information. And I've had a lot of people say, that they got much more specific information than they thought they were going to get. Because I try to make it as, specific to that person as possible without making it, again, I have to phrase everything back in the general, like,
I'll say for me, I love research and data. And so for me, it's very data driven, and I love that.
Yeah. And my patients and clients are all so smart. Oh my gosh. They are such good researchers. So I will tell them, I'll say, here's some ideas of some things. Please feel free to look at it. And in fact, I love it when people say, oh, I read about blah, blah, blah. And then they'll share something with me and I'll say, okay, I'll take a look at it and see. And it's like, okay, if it was sponsored by some particular thing, now we have to really take that into consideration. They have a conflict of interest or whatever, but it's really hard because most people don't know some of the low-hanging fruit, some of the things that we can do that really can make a big difference. And right now I'm in the process of writing a journal article for a CME journal, which is Continuing Medical Education. I'm writing an article with Courtney Gensimer. Have you heard of her?
Yes.
Okay, so Courtney Gensimer, Victoria Daler, who is applying to medical school right now. Victoria is the first author on the paper. She's done a phenomenal job on this paper. And we're writing this with the director of their lab, Dr. Chip Norris. And it basically explains, kind of the approach that I take to treating people with these conditions. So that information will be available, in a single place. I mean, a lot of it anyway, once that paper is published. So I'm excited about that. And I think it will be helpful for a lot of people. But of course, it's like anything. If you read a book, that's helpful. But if you go in and you talk to a consultant one-on-one, that's usually even more helpful. So it's whatever works for that person. Some people, they can listen to the podcast, but that's all they're able to do. And that's fine. I mean, at least I'm trying to make it so that the information is more accessible.
Then when you do your own searches, it can end up being like my teenager that Googled and came up with vascular Ehlers-Danlos and came into my room crying. So you have to be careful with where your sources are, what you're looking at, and make sure it's a reputable source as well, especially online, because we can put anything online.
Yeah. Oh my gosh, that is so true. And nowadays, if you wanted to type in like popcorn causes cancer, you probably would find something that affirms what you're thinking. So confirmation bias is a real challenge. It is very hard.
Mm-hmm. We talk a good bit about like with narcissistic relationships, how it can be gaslighting, but we haven't really talked about it how it occurs outside of a romantic relationship. Can you explain like the medical gaslighting and how that can happen? And ultimately, I read an article today about healthcare betrayal, and it was during the COVID, and people were going to the doctor and getting turned away basically. So what do you have to say to, can you just explain what that means?
Sure. So I had no idea what gaslighting meant up until, within the last couple of years, probably. So I had all these experiences where I would go to the doctor and say, something is wrong with me. And not only did they not like have an answer for me, but oftentimes they completely, I felt like I wasn't heard. I wasn't heard. I wasn't validated. I was just dismissed. And there was no attempt really to help me in a number of these cases. And that's what gaslighting is. It's when, it's like you throw the fuel on the fire, and we can self-gaslight, but we have medical providers that will gaslight us for a variety of different reasons. So, you go in with and explain your concerns, and rather than somebody listening and trying to help you solve this problem, mystery, whatever it might be, instead they blow you off. I've had people say things that providers have said to them that are basically mocking them. And it's like, oh my God, that's really horrible. Any of those kind of experiences really would fit the definition of gaslighting. And we're in such a bad place right now in healthcare. Physicians are stretched so thin, and they are being, in a traditional medical setting, they are being forced to see more and more patients in a day. And, I teach medical students, or I have taught medical students. I guess I'm not currently doing it, but I was doing it up until recently, and I'm still on the faculty at a medical school. And they always start out so eager, so enthusiastic, want to help people, so idealistic. And I think it's a combination of, the system, and, we really kind of destroy that, that part of that person who just wants to help. I don't know the physicians that I know, they really want to help people, but they end up getting so.
The good ones get burnt out.
Yeah, they're burnt out. Yeah, they're burnt out. They don't have the capacity for empathy anymore. And rather than realizing that the system is broken and the system getting changed, some people are seeing, like, I heard once that my dermatologist was seeing 80 patients in a day. Now, that's really hard to believe, but I know people that are seeing 40 patients in a day. Can you imagine seeing 40 patients with EDS in a day? One doctor? Yeah. There's just no way you could do that. There's no way. So, if you're in a system where you have to see a lot of people in a day, you're already late for your next person as soon as they start going into, the next part of their story. And it's just, we're setting people up to fail. And I think that it's really, are there bad doctors out there? No question. Just like there's in any, pick a profession, right? There's going to be, pick any profession. There's going to be some people that, really do not have their heart in the right place. But I really think there's a lot of people that do have their heart in the right place, but they are behaving poorly because they are set up to fail. And I think that we really need to figure out, how can we set people up to succeed? And part of why I started the podcast was I realized years ago that there are things that don't need to be delivered in that one-on-one session, but instead could be delivered on a bigger level. And, like a podcast is everlasting content. You record it once and then people can listen to it years later. So I think that there's things that can be delivered in a more efficient manner. And I would love to see healthcare reinvented in that way. We do a very good job, well, I should say a pretty good job, with a lot of acute things. You've got a broken arm, you've got a broken leg, you've got a discrete acute problem, you've got a kidney stone, whatever. We don't do well with chronic problems, with complex problems, with things that are not easily solved. We do a terrible job with that.
Yeah, or invisible pain.
Yes.
Another one, because that's so hard. What's a 2 to 1 person and 8 to another person. And then pain causes anxiety and depression, irritability. And so you have someone going to the doctor that's frustrated, wants answers, they don't get them. That's not going to make a dynamic for anyone.
Yes. And actually, when I was in a lot of pain in 2009, that was when I that's when the wheels fell off the bus, if you will, in July of 2009. And I was going to this one doctor, and she put her hand on my knee and said, if this next MRI comes back normal, we'll have to accept that this is psychosomatic. And was I having a lot of anxiety at the time? Yes. Was I depressed at the time? Absolutely. No question. Was I not handling any of this well? Yes, that's all true. But what she didn't recognize or appreciate, and I didn't either, was that that doesn't mean that those factors all caused my problem. They contributed to it. I think what happens is we have a problem, we don't get an answer, and then we get more anxious, we get more depressed, we get more stressed, and that exacerbates the pain that we feel, that exacerbates our sleep deficit, and not getting adequate sleep makes our pain worse, which makes it harder to sleep. There's all these vicious cycles that just feed into each other. And it was really, really challenging. And at that time in 2009, 2010 is when I had kind of like my worst experiences with my healthcare team. And, I didn't know what was going on. I was going to say they didn't know what was going on, but, some of them, they weren't looking that hard. But, we also didn't know as much about these things back then either, in fairness to them, I guess. So.
Right. And I think, my patients and our listeners, trauma, thought it's self-blame. It's my fault. I did something wrong. So then when we hear it's psychosomatic, it's in your head, just tap it out. Or here's another antidepressant, here's another whatever. And then you have all these medicines. Do you have any words of wisdom just to be assertive and speaking up?
Right. It's so hard to do that because, we're, as human beings, we are energy beings, energetic beings, right? So if we go into an appointment and we're feeling anxious and, stressed, and that's gonna, the other people in the room are gonna pick up on that. So I think maybe just being completely honest and saying, I know that I have anxiety. I know that that is probably contributing on some level to the pain that I'm experiencing, but I also know my body. And I really feel confident that there's something going on. I need to have an answer. I need to know what the problem is. I need help. I'm coming to you for help. I'm coming to you for help to feel better and to improve my quality of life. And I think that that's really key. And also recognizing the challenges that they're under. So for example, if you're seeing someone in a regular traditional healthcare setting, and if you do suspect that you have a condition of symptomatic joint hypermobility, that you could say, this is what I think might be going on. And it would explain a lot of the symptoms that I've experienced. I know you may not have time to discuss this today. Could I come back for another session, for another meeting? And could we discuss it at that time? And could I share something with you in the meantime? You could upload, I think probably most portals allow you to upload a file. So you could upload like a single article on symptomatic joint hypermobility or on EDS or EDS and HSD. Like, again, keep it concise. We're working on a document that has like some of the very medical episodes of the Bendy Bodies podcast that people can share with their doctor and say, hey, here's a resource that you might find helpful. Because I try to explain to physicians that, if you understand about these conditions, if you take even just a little bit of time to learn about these conditions, it will actually help you. It will help you help your patients. So I like to approach it from, do you have patients with seemingly unrelated symptoms that are coming to you in your office? Well, here's a possible explanation. This might be what's going on, because they have to kind of feel like what's in it for them. What's in it for them, they can help more people.
Right. And fewer visits and, less phone calls and, more time. So broad speaking, generally, what are some of the broad things that kind of come in the umbrella symptoms?
Oh boy. So pain is really, really a big one. I mean, it's, the data shows 80 to 90+% of people who have symptomatic joint hypermobility have pain, persistent pain. And it can be, widespread, and it can be challenging because part of that can be related to the dysfunction of the nervous system, but it can also be related to what's going on in the tissues. So maybe you have a tendinopathy in one part of your body. Maybe you have a joint that dislocates or subluxes frequently in another part of your body. And a subluxation, by the way, is a partial dislocation. So persistent pain is a huge, huge problem. So I'd say that's number one. Number two, we see so many gastrointestinal problems. People with symptomatic joint hypermobility have a much higher prevalence of almost, you name it, like every GI, I feel like every GI symptom. So abdominal pain, heartburn, constipation, diarrhea, bloating, like food intolerances, so many different gastrointestinal problems are super, super common. In terms of getting back to the musculoskeletal, so pain, dislocations and subluxations are very, very common. So the joints are unstable and don't stay in proper alignment well. So we see that a lot. We see the like soft tissue damage. So the tendinopathies, which, oftentimes people are diagnosed with tendinitis, but it's really not an itis anymore. There's no inflammation anymore. But the tendon is, there's damage in the tendon. So we see a lot of tendinopathies. We see a lot of like, bursitis or, like shoulder impingement, a lot of different musculoskeletal problems. We see a lot of problems with proprioception, and proprioception is knowing where the body is in space.
I was going to ask you, that was on my list.
Was it on your list?
Yeah, so related to trauma too, when people have that, but yeah.
Yeah, people, if they kind of are dissociating from their body, then that can make that worse. And a lot of times people will say, I hurt myself doing this silliest little thing. I reached over for blah, blah, blah. And can quote unquote normal or normal connective tissue people do stuff like that? Yes, but we just do it more often. So, it is important to work on proprioception, knowing where your body is in space without looking. It's important to work on connecting with your body in a healthy way, in a positive way. Like touching your body and getting used to positive touch is very important. We get sensitized even to, basic touch. So we get allodynia and hyperalgesia. Allodynia is where things that are not painful are painful. So light touch becomes very painful. Hyperalgesia is where things that are normally a little bit painful become a lot painful. So I know when I was working in the operating room and, you'd start, you'd go see somebody and you'd be checking their vital signs and stuff, and you'd inflate the blood pressure cuff, and most people would, just sit there like, fine. And some people are like, ow, 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 that's something that, yeah, it's a little bit uncomfortable, but for some people it's like painful. So if there's words for these things, allodynia, hyperalgesia, they're real things. It's because the nervous system, instead of like filtering out a certain amount of pain, the nervous system just is sensitized and feels everything as painful. So, this happened to me. I went through a period where, yeah, everything was painful. Thank God, knock on wood. That's much, much better. So that's another thing that happens quite commonly. We also see a lot of headache, a lot of head pain. So it could be tension headache, cluster headache. We see a lot of migraine. Migraine is very, very common. And head pain can be due to a lot of different things. It can be due to dysfunction of the temporomandibular joint. So that's a very, very common problem. People have the jaw. Yeah. Jaw pain is very, very common. People have increased range of motion of the jaw and joint instability of this little joint in the jaw. And so they can get pain that radiates into not only their jaw and their neck, but into their head. People can have head pain or pain at the base of the skull because of Chiari malformation. They can have that because of upper cervical instability. So they can have suboptimal muscular control of the vertebrae in their upper cervical spine. So we see that. We see just so many different things. It's like we see bladder problems. We see pelvic pain. Pelvic pain is another really super common one.
What I was fascinated by was, connecting those dots that, I had celiac, I had food intolerances, I had pain, I had headaches, I had itchy skin, I was getting eye stuff, and then, going to the pharmacist once a month and picking up 20 pills. And then it was just reaching that point of frustration. And it was like, don't give me another medication. So, but it was, you're saying so many things that can be related, but they are actually related.
Yeah. And I'm glad you brought those up, because allergic type phenomena. So, hives, eczema, pruritus, which is, itchiness, asthma, allergic rhinitis, all of these things are more common in people that have these conditions. And you're right, it can end up that, if you're in a traditional healthcare setting, it is a lot quicker to write a script than to go over like all this stuff that we're talking about right now. Even if you knew it, like even if you knew all this stuff, you don't have time in a traditional setting to explain all these things. And like you said, we have to be very careful when we bring up anything related to psychologic factors, because it's very important for people to understand that these psychologic factors didn't cause their problems, but they can just be another thing that can exacerbate them. So if we address them, they can help you feel better. So that's why it's important to acknowledge those factors. So, I mean, I had depression, I had anxiety, and it was making me feel worse. And nobody on my team was screening for those things, asking about those things. I finally said to one of my doctors, I think I need an antidepressant. And they wrote me for
I've
one.
done that. I was like, aren't you supposed to ask like the power 9 or something here?
Right. And I think maybe some practices are doing a better job of screening, but I also think some of us, a lot of us, are also people pleasers. And so sometimes we may answer the questions on those questionnaires kind of how we think the person wants to, the answers that we think that they want to see, or kind of what we wish was the case. And so I also think that there's a difference between, I do use a lot of those questionnaires, but I also like getting to spend more time with my patients and with my clients to really get a better sense of what's going on. And so they feel like they can, I hope that people feel like they can share anything with me and that I'm not going to judge them.
No, great advice. I talked about your program, and I'm going to put how to find you in the show notes and links to your programs, your podcast, everything. Any final words of wisdom for people that are, have these unexplained things going on and kind of want answers?
Yeah, I think that you mentioned it briefly a little bit ago, but we kind of, moved on to the next thing. It's really important to address the symptoms and to treat the symptoms, and think about if you're like, some people I feel like they get overly fixated on having a label. And sometimes I can see why that's important. Also really focus on your quality of life and improving your quality of life, improving your sleep. Poor sleep is another huge thing that we see, very, very common. I think if you can focus on those things, that can be very, very helpful, because it's hard, but physicians are I think often turned off if they feel like someone is pursuing a specific, like I want to, almost like I want to be, not I want to be sick, but maybe I want to be sick. They want an explanation is what they want, right? Is what we want. I wanted the same thing. I wanted an explanation. So I think explaining that I want to feel better. I want my symptoms under better control. I want an explanation. I'm not looking just to have a label just for the sake of having a label, but I want to know what the underlying reason is. And I really suggest that people pursue that line of reasoning rather than, I want this label, because I also want to make sure that we are diagnosing people appropriately, because EDS can look like a lot of other things. So I had somebody the other day that I saw on EduCoaching who had lupus. And I was like, I think lupus can explain all of your symptoms. I don't think you need another diagnosis, and her rheumatologist was telling her that because her labs did not show inflammation, she should not be in pain. And I said,
Oh, no, you have to take those different times of the month.
yeah,
So,
exactly. Right. Oh, and painful periods is definitely another thing that we see commonly. And I told her, I said, just because your labs are normal, or, the ones that they checked are normal, does not mean that that's not what's causing your pain. And it doesn't mean that you need to pursue another separate diagnosis. So I think that's just another important point, that, it's unfortunate that this person was saying those things to her, because they obviously, made her doubt herself and doubt that this condition could explain what was going on. But again, when people only have 10 minutes, they look at the labs, they look at what they're prescribing, and they're going to just like refill it or whatever. And they're like, nope, you should be fine because your numbers are okay.
yeah. Do you want to say, can you check it again in a week, or when there's pain?
And well, the thing is, I think because people have gotten so busy, they have become over reliant on tests.
Yeah.
And our tests are far from perfect. There are false negatives, false positives. Imaging does not show everything. So just because we can MRI almost any part of the body, just because we have a lot of tests we can do, does not mean that we should invalidate the person's experience. We should not be believing our tests over our patient.
The body is so resilient at compensating and pulling from one thing to fix another. So tests can be perfectly fine, but inside we're not.
Right. And actually people with these conditions, for the most part, are incredibly resilient. I feel like a lot of quote unquote normal people, like something happens and that's it. They're like, whereas people that have these conditions, like a lot of them, they just like cope with this, and it's just, because they've had to.
One other thought that would be interesting to mention is, because you were talking about the anesthesiology room as well, the pain medicine for like lidocaine. Because I think that's something people aren't aware of, but I've talked to a lot of people that don't get numb at the dentist.
Yep. And I will tell you that up until probably around 2012 or so, I did not think that it was possible for a person to not get numb with local anesthetics. I just thought everyone gets numb and there's no such thing as a failure of a local anesthetic. If you're doing an epidural, then you can have a failure because you didn't get the needle and the catheter in the right place. But like if you just inject local into the skin or whatever, everyone is going to get numb. And now I know that's not the case. There are some people with local anesthetics, so things like lidocaine, bupivacaine, prilocaine, there's a whole ton of them. And there's people who do not get the same response as other people do. They may need more time. They may need a higher dose. Of course, we have to be careful, like not to overdose somebody. But, some people, they don't get numb when they go to the dentist. They don't get numb when they go in and they have carpal tunnel surgery done under local or a beer block or something. So yeah, that's a very important point. And there's a study being done right now looking at people with EDS and local anesthetic resistance. And it should be very interesting to see what those, I think the results won't be available till at least next year at the earliest. But I believe there was a survey type study that showed that like 80+% of people had some experience where they, didn't get numb. Now, of course, if you send out a survey and if, you're probably going to get some kind of sample bias because people are going to see what the survey is about and if they've had these experiences. So I honestly don't believe it's that high, but there's definitely a higher incidence of people not getting numb with local anesthetics. So yeah, that's an important factor to consider as well.
So I think, takeaways would be to, speak up for yourself if you think something's wrong, make time, make an appointment just for that, go in with a supportive friend and bring these things up. And then your services are available. Remind the website.
Hypermobilitymd.com.
Yes. And the free podcast as well. And also a pretty good Instagram page that people can follow.
Yes. So I have two Instagram pages. One is Hypermobility MD and the other one is Bendy_Bodies.
Those will be linked in the show notes as well. Thank you for tuning in, and we will catch you at the next episode. Thank you again for tuning in to our podcast, Hope After Narcissistic Abuse. We hope you were able to leave with some renewed hope. And if you like what you heard, please subscribe to the channel, give us a review, head to the show notes for more information on the things that we highlighted. And there's also a link to the website for a course that we offer on the same topic, Hope After Narcissistic Abuse. Thank you again, and please tune in to the next episode.